You are now listening to MedEd Talks Primary Care, a Vindico Medical Education production. The following podcast series is titled Expert Weigh-In Podcast Series. To earn CME credit, log into mededtalks.com and search Expert Weigh-In, or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and the learning objectives. Now, here's your host, Dr. Robert Kushner.
Hello, I'm Robert Kushner, professor in the Departments of Medicine and Medical Education and former director of the Center for Lifestyle Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I'll be your host for this exciting new podcast series titled Expert Weigh-In. In these podcasts, I'll be interviewing physician experts on various topics in obesity management. In this episode, we will be discussing the interplay between obesity and MAFLD, which stands for Metabolic Dysfunction-Associated Fatty Liver Disease, mouthful, and MASH, Metabolic Dysfunction-Associated Steatohepatitis. I am so pleased to be speaking to Dr. Lisa VanWagner. Dr. VanWagner is an associate professor of medicine and director of clinical research at the University of Texas Southwestern Medical Center, Division of Digestive and Liver Disease in Dallas, Texas. Lisa, welcome.
Thank you, Bob.
Lisa, as you know, we crossed over during our time in Northwestern, where you did your training, and you recently came back to give internal medicine grand rounds Northwestern last month or so. I was watching it virtually, but boy, everyone was so pleased to welcome you back and congratulate you on how much you have continued to contribute to the field of hepatology and the link between obesity and cardiovascular disease. With those reflections, let's go ahead and get started. Lisa, I want to start by talking about the interplay between obesity and MASH and MAFLD. First, what is the connection between the two conditions, and how does that impact management of patients with obesity as well as with MASH?
That is an excellent question. And what we know is that, first off, obesity is one of the strongest risk factors for underlying steatosis in the liver. And we know that about greater than or equal to 75% of people who have obesity are going to have hepatic steatosis. That's in all comers. If we add other metabolic comorbidities like diabetes, or even in patients who are presenting with abnormal liver chemistry, you can get prevalence estimates that are greater than 95% in people who have all three of those conditions. We also know that adipose tissue dysfunction itself really drives insulin resistance. It drives lipotoxicity. It contributes to hepatic inflammation. So all of those things in the setting of the obese or overweight patient certainly contribute to hepatic deposition of fat and triglycerides. And then when we think about management, it really is complicated by these overlapping comorbidities that, of course, track with the obese phenotype. So we talked about type 2 diabetes, but also dyslipidemia and other cardiovascular risk factors like high blood pressure. And of course, in particular, patients who have even just impaired fasting glucose who don't even yet meet the definition of having type 2 diabetes certainly complicates how we think about managing the patient who has both obesity and who has MAFLD. And regardless of where somebody sits along the spectrum of their liver disease, and we'll talk more about that, I'm sure, weight loss still remains the cornerstone of treatment in this patient population. But like most interventions that are targeted towards weight loss, we know that this is really difficult to achieve and sustain. And it can be particularly difficult in a patient with hepatic steatosis because that metabolic milieu, that metabolic syndrome, right, is so dysregulated that these patients often find it very difficult not just to achieve initial weight loss, but of course to sustain weight loss in the long term. And that is really what's required in order to see a reduction in both cardiovascular disease risk in this patient population as well as liver disease risk.
Excellent brief review of the connection between obesity and liver disease. I think you and I would agree that it really goes undetected and therefore underdiagnosed. I'm an obesity medicine specialist. It's not high on my radar, but it is becoming more higher on my radar as I'm learning more about the impact of obesity and MASH. So let's talk a little bit about, I guess, the barriers of early diagnosis and detection? And what can we do to do better regarding screening for this condition?
Yeah, that is incredibly true. I mean, not just as an obesity specialist, but these patients are an iceberg sitting in all clinical practices, whether you're a primary care doctor, an endocrinologist, a cardiologist, a gastroenterologist who happens to see liver patients, but it's not necessarily a transplant hepatologist like myself. MASH and MAFLD are clinically silent until the advanced stages of disease. So by definition, these patients are going to be asymptomatic for the most part. They will not typically present with any sort of symptoms until they are at the end stage of their disease, which is decompensated cirrhosis. And of course, we want to catch them, as you pointed out, earlier than that. The other really important clinical pearl in this patient population, although AST and ALT as our liver enzymes certainly can be elevated in this disease, and MAFLD and MASH are one of the common causes of elevated liver chemistries, liver enzymes can be normal in this population, and up to a third of patients with advanced disease will have normal liver enzymes despite the advancement of their disease. So you can't just rely on the liver chemistry. In addition, imaging, like a standard ultrasound or a CT scan, may not pick up fat in the liver if less than 30% of the liver is involved. So if you have a patient in whom you're concerned about the disease, you get a right upper quadrant ultrasound for evaluation, and the liver is normal, that doesn't mean that they don't necessarily have MAFLD. So with those caveats in mind, how on earth do you screen and diagnose? Well, we have a lot of population health-based tools that have been developed, and the one that is guideline recommended, not just by the National GI and Liver Societies, but also internationally by the Diabetes Association. The obesity associations are also coming on board, and soon also the cardiovascular associations. It's something known as the Fibrosis 4 or the FIB4 test. What this is it is a non-invasive scoring system that helps you to rule out advanced disease, or what we call clinically significant fibrosis. So people who have at least stage 2 or higher scar tissue in the liver. This score helps you to rule out that population in patients who are at risk for disease. What does the score actually entail? It's the patient's age, it is their AST level and their ALT level and their platelet count. This is a Googleable score. It's available on apps. You can use it via MedCalc. And you can also build it into your EHR. So many platforms like Epic and other electronic health records, you can work with your teams, your IT teams, to help you just be able to sort of dot phrase that in and sort of pull in the last 6 or 12 months of data to calculate a risk score for your patient. The number that you want to keep in mind for most patients who are age 35 to 65 is 1.3. If you get a score that is less than 1.3, you can have a reasonable comfort to say that that patient more likely than not does not have advanced liver disease, and that person can then be re-risk stratified at various intervals based on their metabolic risk. Now, if you get a score greater than 1.3 or equal to 1.3, that doesn't necessarily mean that the patient has advanced disease, but that they do require further testing in order to determine whether or not they might have more advanced disease and then require referral to specialist care.
So let me double back on the screening part. So you're seeing an individual with obesity. What are the triggers to do a FIB4, or should everyone who presents with obesity have a FIB4 score measured?
That's a great question. Now, the guidelines differ just a little bit in how we think about this. The AASLD, the Liver Association guidelines, would say that all patients who have at least one metabolic risk factor, which includes obesity, should be screened with a Fibrosis 4 score. And then how often you repeat that surveillance depends on their other metabolic risk. So if the patient just has obesity, our guidance would say you should repeat that risk stratification if they're low risk in about 2 to 3 years. If they have obesity and type 2 diabetes or obesity and dyslipidemia, that person should have repeat surveillance at more frequent intervals, usually somewhere between 1 to 2 years in terms of repeat risk assessment. So that's number one. The other populations in which definitely need screening are, of course, all patients with type 2 diabetes is a recommendation for screening. And then patients who have abnormal liver chemistries or patients who may have had incidental hepatic steatosis picked up on an imaging test that was done for another reason, which we commonly see, right? Person comes into the emergency department, they have right upper quadrant pain, they get a CT scan, they get an ultrasound, and it incidentally notes hepatic steatosis. That person also should be screened with the fibrosis 4 score. And then, of course, there is a differential diagnosis to fat in the liver, and very important, which we'll talk about as well. Alcohol is an important cofactor in this disease, and so those patients also need to be evaluated for whether or not alcohol use could be contributing to the hepatic steatosis.
Okay, before I move on to other areas like treatment and new medications and so forth, I want you to be clear. What should the primary care clinician be doing, and when should it be handed off to a hepatologist?
Great question. So you have two options. Number one, in all patients who have a fibrosis 4 score greater than or equal to 1.3, certainly if you don't have the capacity within your practice to do a second line a screening test for fibrosis, and we can talk about what those are, that person is the right person that you should be considering referring to GI or hepatology specialist care for further risk stratification and evaluation. Persons who have persistent elevation in their liver chemistries are another population because there is, of course, a differential diagnosis, as we talked about, to hepatic steatosis, alcohol being the most common, but certain genotypes like genotype 3 of hepatitis C. There are other rare diseases like Wilson's disease that can kind of present as anything. There are certain medications that can cause fat in the liver, tamoxifen being one of them, or long-term high-dose chronic steroid use or hormone use can sometimes cause fat in the liver. Those patients, certainly can be evaluated or should be evaluated by GI or hepatology. The other thing to point out is that patients in whom you get a fibrosis 4 score that's greater than 1.3, it is impossible, right, to get linkage to care, specialist care for all those patients if we think about the millions of patients who are going to qualify. So we have second line tests that are available to us. Those include blood-based biomarkers. They also include some imaging-based biomarkers. The blood-based biomarker that is in the practice guidelines currently is something known as an enhanced liver fibrosis score, or the ELF score. This is a proprietary blood test that is a send-out lab. It can be ordered or done through like a LabCorp or a Quest. Sometimes, of course, your center can draw it and send it off. And the company sends you back a PDF that tells you what the composite score is and explains the risk stratification based on the level of that composite score. It's looking at a bunch of biomarkers that are known to play a role in collagen deposition, right? And collagen is what leads to fibrosis in the liver. That score has been validated prospectively in European populations and has been linked to liver-related clinical outcomes. It is a very helpful score. Patients like it because it is a blood test. They're already routinely getting labs done. And if you have an elevated fibrosis 4 score, I can at least say that as a specialist, I have not had issues with insurance coverage, because I know that question always comes up for that ELF score. So that's one tool that you might be able to use to try to better triage who really needs to get the referral and who doesn't. If you have a low risk ELF score in somebody with that fibrosis 4 score greater than 1.3, you can probably keep them in your practice, counsel on lifestyle modification for the hepatic steatosis, repeat their risk assessment based on their underlying metabolic risk.
Thanks, Lisa. I'm going to bring us back to obesity and actually talks about treatment. You mentioned earlier about how weight loss is one of the key drivers or improvements of MASH. Is the counseling different in an individual with obesity with MAFLD or MASH versus not? And how does is the weight loss different in someone that has underlying liver disease?
For the most part, the answer is no, in terms of the counseling. We tend to recommend, very similarly to what we do in the general population, of trying to achieve at least a 5, if not 10% body weight reduction for that cardiovascular risk reduction benefit. And that risk reduction is also translated into liver disease risk reduction. And when we talk about this, we sort of set these different thresholds of what we can expect in terms of improvement in the liver. 5% or greater, we tend to see improvement in hepatic steatosis. At a threshold of around 7%, we start to see improvement in the histologic components of the inflammation in the MASH phenotype. And if you get to greater than 10% and certainly greater than 20%, which is, of course, what we see with our current contemporary weight loss medications and bariatric surgery, you can start to see actual regression in fibrosis stage, which is huge. So weight loss is a highly effective treatment for patients with both MAFLD and MASH. The other thing to say is that counseling in this patient population, if we're going to talk about differences, the counseling I find emphasizing liver health as another motivator really works well for patients, and framing weight loss, as you're already likely doing for the cardiovascular benefits and the physical benefits and our osteoarthritis and other things, framing it as a disease modifying therapy, I think is also very helpful for this population. But don't forget about the liver when you're talking to patients about motivations for weight loss.
You know, those weight loss thresholds are really important. We often talk about treat the target now that we understand how much weight loss is needed for different complications and comorbidities. And the fact you said, 15 or 20% weight loss, including bariatric surgery, achieving that is really a great target. And we have ways to get there now. And you mentioned the medications. I want to go into that a little bit more. We do have really highly effective hormone-based medications. Semaglutide and tirzepatide are two examples. There's others coming down the road, of course, for treatment of obesity along with MAFLD and MASH. Give us an update on where these medications lie regarding their effectiveness and potentially approval by the FDA, if you know that.
Yeah, these are great questions. So I think the biggest hot off the press data is the large New England Journal of Medicine phase 3 clinical trial interim results that were published just online at the end of April this year that showed that semaglutide 2.4 milligram dose, so our obesity dosing, showed both NASH resolution, NASH when the trial was designed, resolution in about 60% of patients. And it also, in a smaller proportion of patients, did show improvement in fibrosis. So it met its two co-primary endpoints. Now that study is ongoing. It's following patients to long-term clinical outcomes. It's important to note that none of the drugs that we have are in the pipeline yet have actually been shown to improve clinical outcomes in the MASH population. So we're basing this all on histology. But as you mentioned, there's a lot in the pipeline. There's SURMOUNT trial with tirzepatide that is upcoming soon. There are many, many other exciting agents that are still coming through the pipeline that we are watching very closely that are obesity targeted drugs, but that work independent of their obesity mechanism on the hepatic steatosis, but more importantly, on that inflammation and those fibrosis pathways. I think the biggest thing coming down the pipeline in the next 6 months is that I am aware, and it has been publicly published, that we are expecting that semaglutide will go before the FDA for conditional approval for a MASH indication in January of 2026. So the PDUFA date for that has been set. Certainly that we expect that this will likely receive a conditional approval for MASH, but we certainly have to wait for the FDA panel to make their determination.
Lisa, I want you to explain a little bit more for me and the listeners this concept of conditional approval. I don't think most clinicians are familiar with that. When it's approved, it's approved. And you use conditional approval. What does it actually mean in this condition?
Yeah, that's a great question. So several years ago, there was a multidisciplinary panel that included the FDA and clinicians and researchers from across the country that met to actually help better design what was known as NASH, now MASH clinical trials. And everything that we know about this disease so far has really been based on this histologic endpoint. And it's really the fibrosis that drives the liver-related risk. And so the trial design has really been focused on trying to reduce fibrosis without worsening the inflammation, but also improving the inflammation, since we think that's the precursor to fibrosis, but without making the fibrosis worse. They're not powered at these interim analyses to look at clinical outcomes. So for the FDA to approve a drug, you have to prove that that medication actually improves an outcome, not just a biochemical or a histologic marker. And so when your drug just improves the histologic or some sort of interim marker that is not necessarily a clinical endpoint, you are only eligible for a conditional approval for the FDA. And the company is then required to further show that that medication actually improves clinical outcomes in patients before it can receive full approval. So that is where this drug currently will likely sit.
Okay. Hopefully they will meet the final approval, right, and really change fibrosis and clinical outcomes, of course,
Correct.
is what we're looking at. Regarding medication, it's interesting. I think of silos because I think a lot of folks think of these as weight loss drugs or obesity medications. And of course, you're a hepatologist who, although very well trained and knowledgeable in obesity, your focus is on the patient comes in with liver disease. Looking forward, who do you think is going to prescribe these medications? Will a hepatologist say, go back to your primary care clinician and let them use the medications? Or do you think the hepatologist community will embrace these medications and it'll be a shared treatment when a patient comes in with obesity and with MASH?
That's a great question. I certainly hope that it will become a shared treatment. Myself, because this is my area of interest, research-based, clinical space, I already feel comfortable prescribing medications for the obesity indication. But I know that many of my GI and hepatology colleagues do not, and reasonably so, because it doesn't have a MAFLD or MASH indication right now. I think that will change if these class of medications, these incretins, actually achieve a MASH clinical indication. We will start seeing GI and hepatologists starting to prescribe these for sure, in the context of working very closely with our other multidisciplinary providers. And I think that really brings us back to this idea, and I know the American Heart Association came out with a scientific statement, but what was about a year and a half ago of the CKM syndrome, of which obesity and MAFLD and cardiovascular disease and kidney disease are all a part of, recognizing the importance of this interdisciplinary and multidisciplinary management of complex metabolic conditions that include obesity very, very frequently. But we have this toolbox of medications, right, at our fingertips, some of which are, obesity targeted drugs that also improve glycemia and are really insulin targeted, other medications that are very specific towards improving cardiovascular risk or specifically heart failure or even chronic kidney disease risk, and now potentially also this liver-related outcome. And so I think we're going to have to start thinking, even as specialists, so much more globally about how we take from that toolbox and choose from that toolbox what medications are going to be the best first-line therapy for a patient based on their conglomerate metabolic comorbidity.
Yeah, I think we have to change to CKLM, right?
Yeah,
they left out the L for liver.
They left a hepatologist off of the panel.
Yeah.
I mean, I don't know what they were thinking.
Yeah, but it's a great perspective, though, is to think of this as metabolic health, multiple organ or multi-morbidity, as we talked about. One more question on practicality, then I want to move to cardiovascular disease, which I know is an area in your training and fellowship and really getting involved with that connection between liver health and cardiovascular disease. When we're managing a patient with obesity and, let's say, MASH or MAFLD, is there any difference in the dose escalation or dosing or side effects if someone has liver disease? Something else we have to be careful about as we're starting someone on the medications and escalating the doses?
Not necessarily in the standard MAFLD patient. The one population in which I think we do have to be cautious is somebody who has decompensated cirrhosis. And so that's probably not the majority of the listeners today are not going to be necessarily prescribing in that population. We do, in the liver transplant community, sometimes use our GLP-1s or GLP-1 type medications as adjunctive therapy to help optimize weight management prior to solid organ transplant. And I know the kidney transplant colleagues also do the same thing, but that certainly requires specialist management, because the other thing that happens in this disease, even at the end stage, right, you can get sarcopenic obesity very readily in somebody with cirrhosis, particularly decompensated cirrhosis. So that's the one situation where some slower or lower dosing especially with the side effect profile, as we're all very aware of the slow gastric emptying and the nausea. You've got a patient with ascites, or they've already got gut dysmobility because of their underlying cirrhosis. Certainly, that is a population in which I think we need more caution. And I will say, to clarify, the conditional approval for semaglutide that is going before the FDA is not going to be for patients with cirrhosis. It will be, and what the New England Journal of Medicine trial showed, is in patients with stage 2 and 3 fibrosis only. So that is the slice of the pie that we're talking about when we're talking about the conditional approval. So it's in clinical studies right now for cirrhosis, but it will not be the drug that we will see for conditional approval in 2026.
Okay, good information. Lisa, I do want to have you talk just a little bit about, as I've said before, the link between obesity and cardiovascular disease. I didn't really, in fact, listeners may not know that the number one cause of death or mortality in individuals with MASH is not cirrhosis, I understand. It's cardiovascular disease, which I think many people don't think of. So as a clinician who's seeing a patient with obesity and comes in and finds out they have MAFLD or MASH, do they need to treat them differently, think differently regarding that risk of cardiovascular disease?
That is a great question. I would argue that the answer is yes. Because I think, like many of our, risk reclassifiers, our CAC scores, our, CRPs, other things that help patients in that sort of intermediate risk category to reclassify their risk into higher risk categories, MAFLD and MASH is likely another one of those types of risk factors. And so in that regard, I think when you have a patient who has underlying MAFLD, and particularly the MASH phenotype, where they have evidence of inflammation or they have evidence of early scar tissue, that patient population is at higher risk than a matched patient population who may just have obesity but doesn't have the actual metabolic disarray that has led to triglyceride deposition in the liver. Their cardiovascular risk is higher. And we've seen that in multiple MASH studies globally. This isn't just in a Western European or a US population. We have very much seen this from the Eastern world and from our colleagues in Asia who've done many studies in this regard. I think it's really important. The other population I think is really important to think about that we haven't talked about is the very, very high prevalence of advanced disease and high cardiovascular risk in our Hispanic population. That is something, of course, here in Texas, and I know also in Chicago that, we have a large Hispanic population that we're serving. Patients in that population are at the highest risk of having more advanced underlying liver disease, but also at highest cardiovascular risk when they have this liver disease present alongside type 2 diabetes or other risk factors. So I do think that is an important, and that might be a person that you might be a little bit more, aggressive about thinking earlier initiation, maybe of, obesity pharmacotherapy in that population to achieve those treat to target goals, or earlier referral for bariatric surgery in a patient population in whom has failed standard lifestyle intervention.
Okay, good to know. Lisa, in just a few minutes left, I wonder if you can leave our listeners with some really important take-home messages. We started off by saying this is an undetected, underdiagnosed, and I think undertreated condition, yet so important to think about in our patients who present with obesity. What should the individuals, the listeners, be thinking about going forward?
I think the biggest things to recognize is, number one, these patients are in your practice, whether or not they've been recognized yet. I think to remember all type 2 diabetes patients need to be screened with the fibrosis 4 score, right? The fibrosis 4 score in patients with 2 or more metabolic risk factors needs to be used in that patient population. And remember that risk threshold of 1.3. Less than 1.3, safely can likely stay in your practice, repeat risk stratification at a pre-specified interval. And greater than 1.3, you have the option to refer, or you have the option to obtain a secondary test, either a blood test, and we didn't have a chance to talk, but there are some imaging modalities that can be done to assess further risk as well. And I would direct people to the AASLD guidelines for more information on that. Your standard of things that you're doing in terms of lifestyle counseling should continue. It is, I think, in this patient population, important to highlight the alcohol risk. I know you're already talking about it because empty calories are empty calories, but particularly in this patient population, anyone with fibrosis should be abstaining completely from alcohol. And of course, as a liver doctor, we like to avoid alcohol as much as possible in this population as well. And then I would say, finally, you've got wonderful medications and therapies at your fingertips to treat that obese phenotype. And it works in patients with MAFLD and MASH, and you shouldn't shy away from referring somebody for indicated bariatric surgery or putting them on that incretin medication if it is already indicated, because it also potentially is going to influence and improve their MAFLD and MASH.
All right, Dr. VanWagner, thank you so much for an excellent discussion. Thank you so much for joining us. And thank you for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series.
Thank you for listening to MedEd Talks Primary Care. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Expert Weigh-In Podcast Series.